Hey, good evening, good afternoon. I'm coming doing this live recording. We're going to do it a little bit early because St. Patrick's Day. Give you all the option to take a little break. Maybe you watch the video whenever. So just gonna go over this chapter and do some gynecology emergencies. So we'll dive off into this. We know the same slide every time. Applies the fundamental knowledge, provide basic emergency care, transport based on assessment, finding, and for acute ill patient. Gynecology will do the recognition and management of how to shock for vaginal bleeding. Got tongue twisted there for a second. Y'all caught me. We'll talk about the anatomy, physiology, assessment findings, management of vaginal bleeding. We'll talk about sexual assault to include appropriate emotional support and potential infections. Let's see. We'll do all right. So we know without going any funny that women are uniquely designed to conceive and give birth. Delivering of birth, having deliverance of a child, a baby, that's really such easy job on our part as the care provider, because it's just kind of a catch. Make sure that there's not a delivery complication. Make sure that everything's handled fine. We open the airway, suction it out so the child can breathe. Other than that, we're just really catching. But on the women's part, it's very complicated. We talk about the different types of complications that they go through. So before we dive off into birth, we'll go over some of the gynecology issues we talk about during the process. We know that women are susceptible to a number of problems that don't occur in men. We just don't have these issues a lot that women do have. We'll talk about the female reproductive system that includes internal and external structures. We'll go over the vaginal opening, the labia majora and the labia minora, the clitoris and the perineum. Here's a picture on the next slide. Hopefully we're all adults through this. So remember that we'll see some stuff going throughout this that may not be used to, but again, it is over the gynecology section. So here we go. So diving off in here, we'll look at the top. We'll talk about the labia minora right here at the top. This is the majora, which is the outer foremost skin. You have your urethra right here, your vaginal orifice. This is the anus and the perineum that's in between. This is where you can also get tears right in here if you're having a large child delivery. They can do like, I think it's like a level 1, 2, and 3 tear. From what I understand, those are very painful. They can stitch those up, or sometimes they may not require stitches. They can do a soft heal over time like that. So into that, just be cautious, knowing the structures, knowing the anatomy, and overall parts of the vagina. So the ovaries do lie on each side of the lower abdomen, and they do produce an ovum, which is in the egg. The fallopian tubes connect each ovary to the uterus. I'm going to show you a picture. We'll make sure you understand that a little bit easier. So the uterus is the muscle organ that where the fetus grows during, there's a picture on the next slide. That's what I was looking at. So the nearest part of the uterus is called the cervix, which opens to the vagina. The vagina is the outermost cavity of a woman's reproductive system. All right. So let's make this a little bit more sense. All right. So let's dive off here. Here's your ovaries right here. This is down into your fallopian tubes right in here. You have your uterus. I can't pronounce today, y'all. So you have your uterus here. This is your cervix, or the opening down into the vagina. So if you can see it when it's crossed out this way, this would be to the buttocks right in here. And this is how it's opening from here point. So you see right in here, same parts, your ovaries, fallopian tubes, down into your uterus, your cervix, and then down into the vagina, into the opening. So you can see it in two different angles, maybe that help you out to understand a little bit better. So then when the female reaches puberty, she starts to begin ovulating and experience menstruation. So that's where everything starts getting serious. So the menarche, or the onset of menstruation usually occurs between the ages of 11 and 16. Any female who reaches menarche, I guess that's how I'm saying it, menarche, is capable of becoming pregnant. So at the age of 11, once they start producing eggs and all, they go through the process, they can conceive a child. So women continue to cycle of ovulation and menstruation until they reach menopause. The end of menstrual activity usually occurs around the age of 50. Words are killing me today. I am tongue twisted all over. So normally you start about 11 and you finish your menstruation about the age of 50. That is about common. A lot of times they can have a full hysterectomy and things like that, that they'll have to go on to have a steroids or hormone pills throughout the rest of their life to kind of balance their body out, but that's okay. We can handle that. Modern technology has helped us out into the ladies' world. Each month, one ovum is released into the fallopian tube, which is considered ovulation. The process of fertilizing begins in the vagina. Sperm are deposited into the vagina from the male penis. Sperm pass through the cervix and into the uterus, and eventually up into the fallopian tubes where the ovum is fertilized. The embryo travels through the uterus, attaches to the uterine wall, and that's where it starts to grow. That is this quick and down and dirty process of how they are fertilized and the process of growth. Oh, let's see here. If fertilization does not occur in 14 days, the lining of the uterus begins to separate and menstruation occurs. Female hormones produced primarily in the ovaries, they do control the process of ovulation and menstruation. I really don't have a lot to talk about this because I don't have any idea. I'm talking just book and personal experience out in the field. I don't have to deal with this, so I don't really know a whole lot of experience to talk to y'all about this, though. So the pathophysiology of is the cause of gynecological emergencies are varied, and they do range from sexual transmitted diseases to a trauma. You can have rape creates trauma. They can have an injury to where they have an abdominal injury and they are bleeding from the vagina. And we never pack the vagina, but we don't stuff anything inside of a human orifice, but we can pad the area when we start to notice that we're having a lot of bleeding. So PID, which is pelvic inflammatory disease. So this infection of the upper organs of a reproduction system occurs almost exclusively in sexually active women. If infection expands to fallopian tubes, it will cause scarring, and it can result in an increased risk of ectopic pregnancy or sterility. If infections expands to the ovaries, it can lead to the development of a life-threatening abscess. Most common presentation signs of a PID is generalized lower abdominal pain. Other signs include a foul-smelling vagina discharge, increased pain with intercourse, fever, general malaise, and nausea and vomiting. Some of the risk factors: multiple sex partners and/or a partner who has had multiple sex partners, untreated sexually transmitted diseases, a history of PID, being sexually active, younger than the age of 26, douching, or using of an IUD birth control. Now, you will also see signs when they start to walk. So we call it the PID shuffle. They don't take normal full strides because it's super painful. So they walk in little bitty strides and they shuffle their feet. That's the PID shuffle. That's kind of a telltale sign that I've seen. Besides being, lower abdominal pain, you still potentially think that you're going for a potential pregnancy until you start asking a lot of questions. A lot of times we ask, are they sexually active? Any possibility, chance they can be pregnant? Everybody says, 99% of people say no, which the answer probably should be yes. But then you have to ask them to walk to your stretcher, and you'll see them as they're sliding their feet across around. So that being the case, that's kind of a little sign that's saying, hey, they may have the potential of a PID, and that's the pelvic inflammatory disease. So that's the PID shuffle to look for. That's just one of the signs that I can teach you about there. So STDs, so sexually transmitted disease. We have STDs can lead to more serious conditions such as PID, chlamydia, most common STD in the United States. It's usually mild or absent symptoms. Infection of the cervix can spread to the rectum and progress into a PID. My puppy's trying to come up to me. Let's see here. So we have bacterial vaginitis. Most commonly, the vaginal infection to affect women between the age of 15 to 44. If untreated, it can lead to premature birth or low birth weight in cases of pregnancy, makes the patient more susceptible to other serious infections and cause PID. Gonorrhea, caused by bacteria that grow and multiply rapidly in warm, moist areas of reproductive tract. It affects the cervix, uterus, fallopian tubes in women, the urethra in men and women. Severe infections present with cramping and abdominal pain, nausea, vomiting, and bleeding between periods. Untreated, it can enter the bloodstream and spread to other parts of the body, including the brain, which is fatal. Vaginal bleeding. All right, so possible causes. So we do have abdominal menstruation. We can do vaginal trauma, which we just talked about very briefly. We can do an ectopic pregnancy, spontaneous abortion, cervical polyps, and or cancer. So patient assessment, how are we going to get ideas about this? Obtain an accurate and detailed assessment is critical when dealing with the gynecologic issues. So asking those questions, getting personal with these patients, asking what's going on, what potentially is the effect, can you give me some more information? Are you sexually active? Have you had any multiple partners? Have you ever had a pregnancy before? Have you lost a child? Those questions are important for us to ask so we know how to build our patient assessment, and we're building a history at the same point. Obviously, scene size up. Is the scene safe? Do we need to go in there? Do I need any type of assistance? How many patients do I have? If y'all remember when we do our checkoff skills, these are some of the questions we're beginning to ask. What is the nature of the illness? Have you taken standard precautions? Do I have gloves, mask, gown? Do I have all that I need to have in there? Some gynecology emergencies can involve large amounts of blood and bloody fluids potentially contaminated with organisms that can cause communicable diseases. Where or what position is the patient found? If she is at home, what are the conditions of the residence? If it's a crime scene, you may be required to testify in court regarding conditions on your arrival. Your documentation needs to be accurate and thorough. Involve police if any suspected type of assault. If we believe that is a potential rape, we have to report that. That is part of our job to report that. We can do it very openly, or we can report it at the hospital behind the scenes and not let the patient know that it was reported that way. In cases of sexual assault, it is important to have a female EMT provider on board. If they don't allow either one of you to touch them, that's fine, but make sure you transport them to the facility and respect everything that's going on. If you potentially go, and I'm sure it'll talk about this a little bit, if you potentially respond to a potential rape, sexual assault, or anything, encourage the patient not to take a shower or wash their hands. In these type of situations, they will have to do swabs. They will do they'll clean their fingernails out, any type of contaminants, and they'll want to take their clothes too. So those things, yes, these females may be emotionally distraught. They want to get clean. They want to wash everything off, but just remind them that's the only way that we're going to be able to get more information upon their assaulters. So our MOI is the MOI of some patients of gynecology problems may be easier understood from dispatch information, such as a sexual assault, and some other patients' history may reveal the nature of condition. So if we ask these questions, just building a history of what's going on, what do we see, how do we understand, and we're able to build a rapport so we know what information we can gather. These are some of the stuff that we have to know when we start to move forward, because otherwise we don't know how to treat them. We just treat off of what little information is provided. Be like, hey, how you doing? I'm Wally with the ambulance service. What's going on? All right, good conversation. So we have to get them to respond to us. And I've told y'all in the past, that's why I enjoy working male-female truck. I have nothing against working double males or even, two females working together. Have no issues with that. But I enjoy it as a provider because now I'm able to also allow my partner to take that time with another female if it's needed or required. I have no issues in that. I've done it in the past. I've allowed my partner to transport all the way to the hospital, and the hospital questioned me why I did that since I'm the paramedic. It's like, it's not about me, it's about the patient and their concerns. So there's no reason why I couldn't transport that way. Our primary assessment, again, always perform a general impression. What do I think is going on? What do I think? Now, you can build from that and go off from there. Hold on 2 seconds. Sorry about that. So I don't know where we were. So when our general impression, what is the patient stable? Is it unstable? What is their APU? I need to know what their alertness level is. Like, are they conscious? Are they able to understand simple directions? Can they follow what I'm asking, what I'm saying? Palpate a pulse and even skin color, temp, and condition helps identify if there's any blood loss. Are they going into shock? How much blood loss are we looking at? Is there any? Or we have a preliminary idea. We're just trying to get as much information as we can because we're going to be asking a lot of questions. Now, there's sometimes we don't have to ask a lot of questions because maybe the patient, when we walk up, look at them and they're breathing and talking to somebody else, we've already assessed their ABCs. If they're breathing, talking, most likely they got a pulse. And then we can build that rapport and saying, hey, yeah, I need to ask a few more questions. You mind if I check your pulse real quick? I'm gonna put a machine on you so I can check your blood pressure as I'm talking. And then if they say yes, I know that their cognitive level is they're understanding me enough and they can answer my questions. If the patient assigns a shock, then rapid transport is warranted, which we know that. So here, make sure that you understand if they need rapid transport, let's transport them. We always want to make sure we get them to the fastest, to the higher level of care the faster we can. I'm a history and taken. We are going to investigate their chief complaint. Some questions are extremely personal. We have to be careful where we ask some of these questions. Depending upon the age of the patient, we may not want to do it around family, a parent or a guardian. Those questions are personal. Be sensitive to the patient's feelings to protect their privacy and dignity. Remember, that's somebody's mother, daughter, sister, aunt. That's how would you want yours to be treated? So when asking these questions, or depending upon where you're at, respect that part. Respect the part to where you know that I need to their dignity and their, keep them covered. How would you want another provider treating one of your family members? For abdominal pain, always ask how long it's been going on. Is this like 2-3 days? What's the quality? Is it radiating anywhere? Is it provoking or revealing factors? What are some of the associated symptoms as syncope? Are we doing lightheadedness? Do we have nausea, vomiting, and fever? Because majority of the time, if it's a female of childbearing age, until they can really show me documentation that they've had a hysterectomy or any other type of female surgery, I'm automatically going to assume that they potentially could be pregnant. I like to be proven wrong. I'm okay with that. But if they are of childbearing age, that's something you had to think about if they start complaining of abdominal pain. Vaginal bleeding, ask about the onset, same thing there. This is a good point right here. So how many sanitary pads have been soaked through? What are some of the associated symptoms and syncope of lightheadedness? So we want to know, is it potentially they called us because they're dizzy? Okay, so tell me, why did you call me right now? Okay, well, I'm dizzy. Okay, what's happened prior to you calling me? So now you ask these questions and you start getting, is it time for your cycle? Well, no. Okay, then you can go on from there. Is this a sharp pain, dull pain? It made me understand, because I'm a guy, I don't know what you're going through. So it made me understand what's going on to paint a better picture for me so I can treat you better. Some questions like that, and just being truthfully honest, may help you out more than anything. And at the same time, as I may ask, hey, is this normal for you to have a cycle this heavy, or are you normally a light person? And asking those questions, because I'm dumbfounded when I try to take care of you, because I don't know, can make me a better provider, because I'm able to actually understand what they're saying because they can relate it to me and I can treat exactly what they tell me. Sample, we obviously want to get a sample history on all of our patients. Ask about birth control pills or any type of other pregnancy devices. Ask about the patient's medical conditions in the last menstrual period. Why is that important to me? I need to know roughly, again, are they potentially pregnant? Is this a spontaneous abortion? Or, what potentially else is going on? And if they say, oh, I was on my cycle about 25 days ago. Okay, well, it can fluctuate. I from what I've learned, they can, move, plus or minus. So is this a normal cycle, or, I don't know. I'm just writing information down and we're going to build from there. So asking our sample questions that relate to the gynecology part is going to build us a better information about what's going on with this patient. Obviously, we're moving into our secondary assessment. So our patient's secondary assessment findings should include this: vaginal signs. What is their blood pressure, skin color, orthoscopic vital signs? Abdomen, distension or tenderness. Is there a bubble to where it's distended? And how tender is the stomach? Is there visible bleeding that I can see? And what is their mental status? Okay, I'm not going to be like, oh, well, I need to take a look. No, because I'm just possibly disrespecting the patient, the family, but they can tell you, I've bled through, a couple pads, and I've had to change my underwear a couple of times too. Well, what that tells me, that tells me what I need to know, and I'm okay with that. That answer to me is like, Roger that, let's move on. If they're able to answer that and provide that information, I don't have to worry about their mental status. They're cognitive enough to paint a picture to where I can understand it. Checking their vital signs, the blood pressure and all that, to me, that's my baseline. Now I'm going to be moving into my secondary assessment. So about this time, your machine should be cycled into checking it for another time period. If you potentially find this patient in the restroom and they're sitting on the toilet, and they're actively bleeding, we have to prepare them. We, by no means do I say, do we pack the wound, but we pad the area. If we need to make sure that our ABD pads, our trauma pads, are something that they can pack. Now, I'm not trying to say we can't transport them without any underwear on, but sometimes it may be easier for them to pad the area and put some garments on underneath it or over it to hold it in place. They're going to take them off and remove them as soon as they get to the medical facility, but makes the patient feel a little bit better to have some underwear on. It's okay. That's fine. Let's transport them like that. Physical exams should be limited and for professionals. So when we transport these, we have these same nurses. These are sexual assault institute nurses that are trained specifically in that. The more that and I don't want to say the more that you examine an area, the more that it becomes more sensitive, becomes swelling, so we don't want to be constantly like, oh, okay, let me look, okay, I mean, on and all, it's fine. Put it on there, leave it, and let somebody at the hospital do that. Only examine the genitalia if necessary to do so to treat the patient. Patients aged 65 years older may have concerns related to hormone replacement therapy, cancer, pelvic floor collapse, and urinary incontinence. I don't know what I'm looking for right there. Now, I have had a really good friend of mine that responded to a traumatic injury to where I don't know what happened, but the lady ended up having her feet on the dash and caught a lot of traumatic injuries to the genitalia. And he was like, bro, I know what I was doing. I just knew anatomically there were some things missing that should have been there that were supposed to be, and there were some holes where they shouldn't. So he ended up having to like visually see, pack the area, and apply multiple dressings on there. So that's why it's important for us to know the anatomical parts where they're supposed to be, and that way to where if we're like, well, that's not supposed to be there, it gives us an idea of what we need to do to potentially treat it, or look around the area. Maybe, it's not there for some odd reason. Is there, let's say if there's glass that's shattered and now it's poked into the pelvic area, we'll need to be careful because I don't want to pad and put air pressure on the area to where now it's going to push the glass more deeper into the area. For vaginal bleeding, visualize the bleeding and ask about quantity, and quality. Observe for vaginal discharge. Fever, nausea, and vomiting are considered significant in the gynecology emergencies. Syncope is considered significant. Treat as being in shock until proving otherwise. you can only lose so much blood and then you go into shock. So that's our thing, is we have to make sure that we provide enough care to keep them from doing that. We don't want these patients to go into shock. We want them to be normal as the best we can. But sometimes when they lose a lot of blood, we have to be cautious. Vaginal discharge, those are one of the questions that I'm going to have to ask. I mean, have you noticed any type of other discharge? Have you noticed any clots? And then some people will be descriptive to you. Some people will just be shy about it. And I get that, but some of those questions need to be asked. And sometimes some people that may not know how to answer that question because they're shy, and they're just like, they're like, it's all right. I'm gonna get you to the hospital and we're gonna get one of the females to help you out as soon as we get there. Just because I may be stuck on a double mail truck that day. And that's a personal question. Assess the patient. Again, here's everything we need to do on our vital signs. I mean, we're going to continue to do that. Is if it's a rapid, or if it's a critical or non-critical, we're going to do these all the time. So we're going to reassess the primary assessment. There should be a few interventions with the gynecologic emergencies, because we're just going to pad the area. We're just going to put pad over it. If it bleeds through, we'll put some more and put some more. And eventually it should stop. If not, the patient will go into shock. And then, because we know we've lost a lot of blood. So that's kind of our two really things. We're not going to have a lot of area. We're not going to be trying to remove anything or, continue to pack there. That's just not what we do. Communicate all relevant information to the staff receiving hospital, obviously, because they don't know either. You're bringing them a patient that's maybe unresponsive or responsive because of what we've told them. That's really all that they know. So we have to tell them everything. Emergency medical care, maintain the patient's privacy as much as possible. Again, that's somebody's mother, sister, aunt, cousin. Let's be, very protective about that. If you're in public, move the patient to the ambulance. Get somebody to hold up a blanket where people can't see them. If you're in the aisle of Walmart, put 2 people on each end or 4 people on each end, or 2 on one and 2 on the other, and hold up a blanket so you can protect that area. Again, it keeps saying have a female participate in the patient's care. If we have it, if we don't have, we're working on a double mail truck. It's all we got there, cowboy. It's best we can do. Excessive internal vaginal bleeding. Use sanitary pads on the external genitalia to absorb the blood. Document the number of pads that were saturated with blood. The external genitalias have a rich nerve supply. It's just like man's face and your head. If I nick this while I'm shaving, which I don't shave often, I'm going to bleed a lot. It's the same thing down there. And then for the female genitalia, if they nick that, cut it, traumatic injury, it's going to bleed a lot. It's very venous. I don't know of a service that has sanitary pads that stay on the truck. We would use something like a ABD pad or a trauma pad, or a certain type of gauze to place on there on the genitalia injury, because it's going to do the same thing. It's just not a specifically designed sanitary pad. It's going to be very painful when they have any type of injury or traumatic injury there. Same thing for the men. When we have genital injuries for the men, very painful. It's not going to be any different for a female versus man. It's just they're both painful, and we're going to take their word and treat them like that. That is super painful. Treat external lacerations, abrasions, or tears with sterile compresses. Under no circumstance should you pack or place dressings in the vagina. We don't want to do that. That's not. It's not in your scope of practice. So do not pack the wound. All right, so let's do assessment and management of specific conditions. So PID, a patient with PID will complain of abdominal pain. We know that. Pain will usually start during or after normal menstruation. The pain is made worse by walking. Patients often present with a distinctive gait and appear as they are shuffling. It's the same thing I told you, it's the PID shuffle. Let's see here. Pre-hospital treatment is very limited. There's not much we can do there. Non-emergency transport is usually recommended. A lot of people still want to go to the hospital by ambulance because they think they're going to get in faster. Not these days. They still going to sit out in the waiting room for another 8 hours. Again, sexual assault and rape are common in the U.S. Unfortunately, 1 in 5 women have reported being raped. That's probably an important number to remember. That is very sad, but that potentially is a test question. 1 in 5 women has reported being raped. 1 in 3 women will be sexually molested, often before the age of 12. EMTs called to treat a victim of sexual assault force may complex any assaults face many complex issues. Issues range from obvious medical ones to serious psychological and legal issues. Remember, again, those questions, if somebody's trying to guard the area and saying, no, they can't go without me back there because I'm their parental consent, I have to make this. And the patient is very timid on answering or providing questions that may be why, or providing answers to those questions. It may be why, because it may be an assault issue, or it's one of those I'm in charge kind of things. You may be the first person the victim has to encounter. Professionalism, tact, kindness, and sensitivity are very important. Again, this is a situation that we don't want to be a part of. They don't want to be a part of, but we are now involved. We have to show kindness. We have to show to be very important. We have to show all these things to make sure that the patients understand that it's okay for them to let us in their circle and understand what's going on, because we're there to take care of them. Get down to their level. Don't stand above them. Let them maybe be a little bit higher than us. That's okay. We got to sit down on the floor with them. Sit down on the floor. But it's okay to get law enforcement involved because it's for the safety of you and the patient. When performing your assessment, be aware of drugs used during sexual assault or rape to incapacitate the person. If possible, give the patient an option of being treated by a female EMT, and just be like, hey, listen, I understand what's going on. Would you like me to call another provider here to take care of you? I have no problems in that. And it's okay for me to let a female come and take care of you. And that's what you want. Just please nod yes or no, and I will turn around and get somebody here as fast as I can. That's simple communications, and that provider may be like, it's okay. Don't take that personal. Step back, call dispatch on the radio, call them on the phone, and just explain it to them, and they'll dispatch you, and you'll go in service, and now the next call is yours. You should, some of your focus should be put on provide medical treatment, the psychological care of the patient, preserve all and any evidence that we can come across. It may be necessary to persuade the patient not to clean themselves, like I told y'all a while ago. Offer to call the local rape crisis center for the patient, and any majority of the hospitals, like if you go to a trauma hospital, level 1, level 2 in your area, they're probably already going to have a SANE nurse. So they're going to do those steps and contacts for you, and that's more of their lane to go down and talk with those patients about that, because we don't have a lot of after the fact after that. So if we ended up doing that on the front end, we may be the ones getting those phone calls all the time, and it's not for us, it should be for the patient. Take the patient's in history and limit any physical examination to a brief survey for life-threatening injuries, because we don't want to mess up any potential criminal issues. We don't want to mess up the scene. If there's potential something on their clothing, we don't want to disturb it. If you have to cut anything type of clothing, always cut along the seams, like on your seams right here on your shoulders. You always want to cut around those. You don't want to cut straight through up and down the shirt. Try your best to cut along the seams. That's the best way to preserve any type of evidence. So here's a table that shows you the treatment principles for sexual assault. This is pretty good. It's in your book at 24-1. I'm gonna leave that there for a second. Give me just a second. I'm gonna turn my screen off and let y'all, I gotta do something real quick. As you can see down on number 7, so the SANE stands for Sexual Assault Nurse Examiners. They can fully evaluate these patients, perform medical and forensic examinations, and provide all aspects of medical and supportive care for these patients. We're not trained for that. We can potentially get that training down the road, but let's take them somewhere that we know that there is one. Over time, you getting out into the career and getting out into the field for EMS, you will learn what particular hospitals have these SANE nurses. These are important. We unfortunately go to more of these calls every single day. We go to more of them and more of them and more of them before we realize we're like, man, we're seeing a lot of these sexual assault calls. It's not something we want to do, but it's part of our job to treat these patients. So learning that and moving forward can help our benefit of our patients. You see right here on number 6, this says handle the patient's clothes as little as possible, placing clothing and any other evidence into a paper bag. If the patient insists on urination, ask the patient to do so in a sterile urine container. If it's available, also deposit the toilet paper in the bag. Seal and label the bag for law enforcement. This can be critical information. That's outside of our lane too, but we do, majority of your ambulances do carry paper bags. We don't want to use plastic because it can sweat and take off any type of other kind of contaminants. Well, this is the end of the class. I know it was super short. I went through everything, but again, we wanted to pre-record this because it is a cool holiday. I hope everybody enjoys their St. Patty's Day. If not, you will enjoy it this weekend, I'm sure. Maybe go to a parade or anything. But here is your class code. Make sure it is the capitalized and the dots all in there. So it is Happy St. Patty. Guys, if y'all need something, please reach out to me on Discord. I will be able to answer some questions. And I hope to see y'all Tuesday. Peace out. And y'all have a great weekend and be careful. If you need something again, hit me on Discord.